neurologic features and severe sars-cov-2 infection. Definition will represent neurologic factors in acceleration. Series of 58 of these four can occur pressure administ the hospital because of acute respiratory distress syndrome.
I'm Elizabeth Esty for the Emergency Medical Minute. Welcome to another edition of the COVID-19 Digest, the podcast where we give you the numbers and sort through the most pertinent research on COVID. It's April 22nd, and looking at the Johns Hopkins coronavirus dashboard today, it looks like there are 2.6 million total confirmed COVID-19 cases across the globe, with 840,000 and some COVID cases in the United States. Total deaths across the globe stand at 183,120. In the United States, 47,750 people have died of COVID. 14,000 of those in New York, 4,700 and so in New Jersey. Colorado, luckily, is not among those top states, but we have, as of today, lost more than 500 people to COVID-19. And New York City is now the fifth. Essentially, they're treating it as a country, and it's the fifth in the world now for deaths. Colorado today has reported more than 500 patients dying of COVID. A newish and interesting feature of the Hopkins dashboard is that you can now look at the total number of tests conducted in the U.S., as well as the number of tests conducted in every state. There's been increasing attention to evidence that suggests that many patients with COVID have neurologic symptoms, and that some patients may even be presenting with neurologic manifestations of the disease. We all know that most COVID patients have a cough, respiratory distress, and while clinicians often speak about how similar the presentations of patients with respiratory COVID are, it's worth looking at the possibility that COVID may have atypical presentations as well. Most COVID patients have normal neuro exams, excepting that high rate of anosmia, which we've discussed before, and which I will circle back to later on in this episode. What we don't know is if patients with atypical neurologic presentations are simply the unlucky few. They had a stroke or a seizure or trigeminal myalgia or whatever, and the phenomenal bad luck of also getting COVID. Many, of course, particularly of the older, sicker patients with COVID, will develop neurologic findings, mostly non-specific findings, as a consequence of being really sick. They're hypoxic, intubated, and they're having the metabolic, hematologic, immunologic, you name it, derangements of being gravely ill. We've talked about cytokine storms, that cascade of immune chemicals that the body releases as it tries, sometimes trying too hard, to fight off a virus. Sick ICU patients are often encephalopathic. They're weak, they're headachy. These non-specific symptoms like headache, fatigue, muscle weakness are what people with milder COVID, or really people with any viral illness, are familiar with. These are not what neurologists would consider primary neurologic presentations. Neurologists are accustomed to seeing severely ill patients in the ICU develop encephalopathy, critical illness myopathy, neuropathies. Most cases of COVID-19 related neurologic complications appear to fall into this category. Neurologists do feel more confident in calling a disease a primary neurologic disease when they have focal signs. That is, things like weakness on one side, one body part affected, a cranial nerve.
Application in nursing. In the case of patients with cancer disease, nursing care is to decrease the rate of transmission
complications and perhaps
to the patient and health.
In the study of 214 hospitalized COVID-19 patients in Wuhan, researchers reported more than 35% had neurological complications, including decreased levels of cognition, stroke, and muscle damage. Their findings, published in the journal JAMA Neurology on April 10th, found 36.4% of those studied had neurologic symptoms. Among patients with more severe infections, 45.5% showed neurologic manifestations. Not all patients with these symptoms exhibited common manifestations of the disease, namely a sore throat, dry cough, and diarrhea. The news comes after previous reports that many COVID-19 patients experience anosmia, or the loss of smell, hyposmia, a reduced sense of smell, and dysgeusia, the distortion of the sense of taste. These reported symptoms may indicate other ways in which the coronavirus could affect the brain. Separately,
Wash your hands with masks. cons, respiratory diseases, cardiovascular
Charge on the
diseases.
International Collaborative Consortium, which is endorsed by the Neurocritical Care Society, of trying to put all these neurologic complications. Are they real? Are they not real? Are they due to COVID? Are they a red herring? She's trying to put really, separate facts from fiction and trying to get an evidence-based approach towards all of this. So, Sherry, thanks so much. I read about you initially, and when you were quoted in the New York Times article. I'm sure you've gotten a lot of feedback and unsolicited emails and phone calls and all sorts of weird stuff. I can only imagine. Why don't you tell me a little bit about kind of what you were quoted about and what you've really been doing and the efforts you've been doing to try to figure out, what are the true neurologic complications of COVID-19 and where to go from here?
Wow. Thank you so much. Thank you for that introduction, and thank you for this opportunity to speak to you about this. Let me just tell you that, as we all have been hit in the face by this COVID-19 pandemic, the whole idea really started out with a group chat that I do with a group of fellow neurocritical care colleagues and providers, and as intensivists, neurologists, but intensivists, we are all on the front line. We have all been very, very busy in developing emergency response plans, trying to adapt ICUs to all sorts of preparedness. But behind all that, we read the reports out of Italy and Europe and now New York and all the other hard-hit areas, and we began to worry about our neurocritical care patients and what might happen to them when our resources are so limited and when we don't have enough ventilators, and we don't even have enough intensivists, because many of us have been now pulled to staff COVID-19 units, and those are all the patients we see in the hospital. And so it started with an idea where I said to my colleagues, this is going to be really hard, but we have to keep a record. We have to collect some sort of data, so that when this hurricane blows over, we can
apply in Ecuador. Clinical data were started for electronic medical records, and day of neurology scientists chest by two trained neurologists.
Anosmia, that is the inability to smell. That could be the virus invading the olfactory nerve directly, but it could also just be immune mediated due to antibodies or other more general immune system responses to infection. I'm sure many of us have had the experience of having a cold and just not being able to smell for a while. It will be interesting to see if there are patients who lose their sense of smell or taste with COVID who just don't get it back or don't get it back in the same way. I have not heard reports on that yet. Early on in the pandemic, there was not a lot of attention being paid to neurologic symptoms. An article in the New England Journal in late February looked at a series of 1,099 patients in China and found that just 13% of them had a headache and didn't really mention much else in the way of neurologic symptoms. At that point, though, these researchers were just trying to wrap their heads around the disease. They were mostly interested in the fact that many patients presented without a fever and that many on their first appearance at the hospital had no radiographic findings. They were, of course, very interested in the fact that 5% of them went to the ICU, 2 and a bit percent ended up on a vent, and 1.4% died. In stark contrast, there's another study out of China that was published more recently, but looking at patients over a similar time frame. This was a study, a retrospective chart review by 2 neurologists who looked back at the charts of 126 patients. Of those 126, 59% had non-severe infection, 40-ish% had severe infection, judging by their respiratory status. The researchers found that 36% of all these patients had neurologic manifestations. Not surprisingly, the severely ill.
Conclusion: patients with COVID-19 commonly have neurologic manifestations during the epidemic period of COVID-19.